Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Drug shortages continue to pose significant challenges for hospitals and health systems. They gained national attention during the COVID-19 pandemic, but pharmacy departments have managed them for decades. During high-profile shortages, institutions must rapidly establish command centers, engage stakeholders, and implement plans for frontline staff. Once resolved, shortages often recede from immediate focus until the next crisis. However, pharmacy departments consistently manage shortages on a daily basis, often without recognition. Today, we welcome Dr. Kyle Hoelting, Senior Director of Drug Information and Drug Shortages at Vizient, Dr. Heather Warhurst, Director of Drug Use Policy, Quality Initiatives, and Regulatory at IU Health, and Dr. Chris Nagy, Medication Sourcing and Supply Pharmacist at Intermountain Health, to discuss a Vizient workgroup project designed to measure the impact of drug shortages and highlight the crucial role of pharmacists in their management. I'm Stacey Lauderdale, Associate Vice President at the Vizient Center for Pharmacy Practice Excellence and your program host. Kyle, welcome back to the podcast.
Thanks for having me back.
Heather and Chris, introduce yourself to our listeners. Heather, you go first.
My name is Heather Warhurst, and I'm the Director for Drug Use Policy here at Indiana University Health. IU Health is a 15-hospital system that provides a wide range of care for patients, including infusion services, acute care, and primary care. As the Director for Drug Use Policy, I manage our system formulary, which encompasses all of those areas, as well as co-lead and manage our system drug shortage call.
And my name is Chris Nagy. I am the Medication Sourcing and Supply Pharmacist at Intermountain Health. Intermountain Health is a 32-hospital system across 4 states. My role is to support the acute and infusion spaces with sourcing supplies, so various 503B pharmacies, alternate sources, direct ordering, as well as working closely with our GPO and wholesalers to make sure that we have enough product for our patients. I work closely with the 32 buyers at the systems. I do some training with them, make sure that we have best practices, and I have various other projects when I'm not doing drug shortages.
Thank you both for introducing yourselves. We feel very fortunate to have both of you join us today. Kyle, can you tell me about the Vizient Workgroup project? What was it, and why did you decide to pursue it?
This project was to create and identify key performance indicators for drug shortages. As we look back at last year, per ASHP in Q1, we had a record high 323 active shortages. We ended the year at 271, which seems like a big decrease, but 271 active shortages is still an extremely significant and impactful amount for our hospitals and specifically our pharmacies to mitigate and manage. Thinking through that, we had a question posed to us by a pharmacist involved in drug shortages. How do we tell our story to pharmacy leadership and the C-suite? From that, we decided to pursue our KPIs. These KPIs, or KPIs in general, are metrics which provide insight into progress towards a strategic organizational goal. The specific purpose of the creation of our KPIs is to highlight the clinical and operational expertise required to manage and mitigate shortages, as well as to advocate for financial resources for our pharmacies in the management of these shortages, whether that be financial resources to hire a new technician, purchase a new software, etc.
That sounds like a bold undertaking for sure. Can you describe high level the key steps taken to develop these drug shortage KPIs?
In April of 2024, we had our first kickoff meeting. Within that, we decided that we needed to create 4 individual work groups, those being inventory, labor, patient safety, and stress and burnout of frontline staff. The format or flow in which these work groups transpired was a pre-survey to identify KPIs that the group may be interested in, a virtual meeting for the group to discuss those KPIs, and lastly, a post-survey to vote on consensus for inclusion in our white paper deliverable. Consensus was met when 60% of the participants within that work group agreed upon its inclusion in the white paper. From all this work, we were able to identify 16 drug shortage specific KPIs, which did not exist before. All of those KPIs are listed within our white paper. We will link that out in the show notes of this podcast.
That was a lot of great information. And again, for our listeners, if they want to read more about it, we're going to link to the white paper in our show notes. Chris and Heather, each of you participated in that focus group. Can we start off and discuss which work group each of you joined and what were your experiences with joining this national work group?
I enjoyed the collaboration with the groups. I participated on 2 of the work groups, the patient safety work group and then the stress and burnout of frontline staff.
If I could just put a plug in for Vizient, we're doing a lot of these focus groups in 2025 as well, including one around formulary frameworks, as well as one around GLP-1 stewardship. There's always opportunities out there to join into one of these work groups. Back to this drug shortage KPI work group. Chris, you told me you were on the inventory work group. That work group developed 3 key performance indicators. One related to PAR adjustments, the second related to tracking back orders, and the third relating to cost differences between preferred versus non-preferred items. Can you explain to the listeners how tracking this type of information can be utilized by your team and what changes, if any, can be made based on tracking that information?
Yeah, these are different metrics than most people think of when you're talking about shortages. Usually it's just how many hours of meetings am I spending or how much communication are we sending out. But these 3 that we came up with were numbers where you can track. One of them is tracking time, the PAR adjustment one. So how much time are your technicians spending going out to the floor, going to ADMs to adjust inventory so you can bring product back to the central pharmacy or move it from one place to another where the higher utilization is to manage this shortage. And that's not meetings and it's not communications and it's not drug information reviews. It's time that the technicians are spending out. And the pharmacy directors have to budget their time, their staff. These are dollars that they can say, I'm spending so much time, I'm spending so much dollars on this shortage issue, and it shouldn't have to be, but it is part of the budget now. That part is getting down to the technician. It's getting down to the frontline staff of the pharmacy who are making these adjustments related to shortages. Tracking back orders goes to best practices. We always tell our buyers, place back orders for an item that's on shortage. And if the back orders are placed, then we have a reliability that when the product does come to our wholesaler, we can get first in line. Tracking those back orders, making sure that we almost have a one-to-one relationship. Then the cost differences of the preferred versus non-preferred. This one, we do have to take into account the Vizient NES. The costs aren't always going to be higher. But if it's a non-Vizient product that you're ordering and you have to pay more for the item, then you can track those costs. It's a hard number that you can say this shortages, because you're not going to be able to say this particular shortage cost me more, but shortages are costing us X amount of dollars. Those cost differences can impact your budget and impact the ability to serve the mission for your facility. Those were different items that we wanted to focus on and be able to track and be able to look at from system to system or even year to year or even from hospital to hospital inside your system. They were all valuable.
Thanks, Chris. As I was listening to your answer, one of the things that spoke to me was technician hours, and it's really about budgeting for that. That brings us to the next work group, which was around labor. Drug shortages shouldn't be happening, but I feel like for the past 20 years, they have been happening. So we have to account for the labor that we need in order to manage the drug shortages. Chris, you have a dedicated team to drug shortage management, and tying it back to the KPIs that were identified by the labor work group. What benefit can we see from documenting time spent managing shortages?
The documentation of the time and in the KPIs, there's specific ones. Those breakdowns help with the budgeting and collecting data to be able to compare our system to other systems or our system from year to year. All that data is valuable, and it helps us to see if our program is getting more efficient. We are more efficient. In pharmacy in general, we're way more efficient at shortages now than we were 10 years ago. It used to be a fire drill every single time a shortage comes up. Now we have a team. We can put it together. The costs are going down. It'd be nice to be able to see and then compare and say, we've implemented a new EHR. Does that help us, or has that harmed our ability to react to these shortages? We have a new wholesaler. Are we getting better results and better reporting? And so we can reduce those costs that are related to the shortage. And then to be able to compare ourselves to another system, if we can find another system that's similar sized and similar number of beds, those would be good comparisons. And that's why the metrics are important to be able to track. It was interesting because we've been tracking my time, the drug informations team, our system level resources over the last couple of years. When we went from a rotating leadership, we dropped about 25% because we didn't have any handoff anymore. There was a weekly handoff that was being taken care of. Now, with one single person as the point of contact, that's been reduced. We're going to be switching over to a single integrated EHR later this year. I have the metrics now. I've got 2-3 years worth of data. Once that happens, we can see if that drops. I'm just excited to be able to show a decline over time.
Thank you, Chris. Let's switch gears from the operational components of the work group series, which were inventory and labor, to more of the patient care aspects of the work group. Heather, I want to pull you in around this because you intended these. Now, we know that shortages absolutely create extra workload, but they also create burdens for patient care as well in terms of medication errors and having to choose different medications. Can you describe what that looks like in terms of a national shortage around how decisions have to be made quickly, how they affect treatment for our patients, and ultimately perhaps our patient outcomes?
When we look at shortages and how they impact patient care, there's 3 things that I think mostly about in regards to that. And our KPI around this was looking at the percentage of drugs in shortage that lead to alterations in treatment plans. With the first point of that, we look at our interrupted, modified, or delayed treatment. This can be caused by a number of different medications. However, what most people are probably in tune with is chemotherapy agents that can cause those delays. A few years ago, when we had the cisplatin shortage, there was a lot of discussion in regards to patients and who should be treated and not. A lot of that we have to take not only from a pharmacy perspective, but you have to bring in ethics and physicians and other people to help with those decisions, which can then ultimately ensure the right patients are getting treated. The second one that can impact patient care is delays in patient care. This has to do with, for over many, many years, emergency syringes are on back order, then they're available, and they're on back order and they're available. You might have to adjust what's in your code carts or what's on your patient care areas. If this isn't readily available, or you had to decrease the number of syringes that you do have available and more are needed and they have to get them from pharmacy, then that does cause potential delay in care of treatment of those patients because that medication's not readily available to them, or they had to use a kit or something else that they're not used to using. Third, when we have to change, we want to keep the same medication, but you might have to change the dose or the concentration. That can definitely cause a patient safety issue. We, a few years ago, had to change our ketamine concentration from 10 milligrams per mil to 50 milligrams per mil, and then even 100 milligrams per mil at one point. That could be a tenfold medication error if the nurse or physician didn't recognize that concentration change. You have to make sure that there's lots of communication in regards to what those changes are, because that could impose a huge medication safety risk for that.
I sat in on the discussion of this particular work group. There was a lot of discussion around how difficult it is to track medication errors and to really operationalize that. Can you discuss some of those challenges? We all know it can create patient safety challenges, but it's sometimes difficult to track those.
I agree. That was a huge part of our discussion, was how do we track those? And with medication errors, there's already this stigma around it. Number one, we have to ensure that they are getting reported. Number two, sometimes the nurses or the person that's reporting it may not realize there was a drug shortage, and that's what contributed to it. If they don't put it in their narrative, this was secondary to a drug shortage, we have to ensure the people who are reviewing those reports that come through know about the drug shortages and that they can code it a specific way, or they can note that in their system. The people who are managing the drug shortages, like Chris and myself, can then go back and put different mitigation strategies or add additional education so that doesn't continue to occur in the future.
In addition to patient safety, everything we do, the patient is the center of it. You've both discussed there's a lot of work on the frontline staff to handle shortages, and that leads to a lot of burnout of the frontline staff. And that was the final work group, was around stress and burnout to the frontline staff. I also attended that group, and that group sought to determine how best to measure that burnout, how best to communicate staff shortages. And I know, Heather, you said you also attend this group. Can you talk through at Indiana how you all communicate out shortages?
Communication is key. In order for us to be transparent with the whole healthcare team, we have to communicate. And that's something that can be a struggle. And it was initially for us. And we've done a lot of different things to ensure that that communication reaches the frontline staff. We have a weekly call where it's multidisciplinary. We don't discuss all 335 medications that might be short that we're monitoring, but we discuss the ones that we're mostly concerned about or that we need to put a mitigation strategy in place for. After this call and those decisions are made, I send out a weekly email that goes to multiple disciplines across our system. It describes what medications we're monitoring and what mitigation strategies are in place. In addition to that weekly email, because not just one mode of communication is good, we post that to our intranet as well and have a dashboard that we've created that if people want real time, they can go look at that information to see how many medications are short, how many we're monitoring, as well as which ones might have mitigation strategies in place. We try and ensure that there is multiple layers of communication to our pharmacy frontline staff, but then also our nursing frontline staff, as we have nursing partners that receive these emails and then send them out. In addition, we have a Microsoft Teams page that people can go in and put questions that they might have for us if they occur before we have that weekly meeting.
Thanks. And Kyle, I know for the frontline stress burnout work group, we developed 4 KPIs. One of those KPIs was to determine or assess how well the communication was working in terms of satisfaction. Can you walk us through that?
Yeah, what we're really getting at is when you look at drug shortages as a whole, there's surveillance, assessment, and then action. You're surveilling the market for drug shortages. You're then assessing the criticality of them. Once you assess those of critical nature, you need to act on them. And a big piece of the action is communication.
Kyle, what are the next steps? We know that we've published the white paper. What is the call to action for our listeners?
The call to action first is take a look at that white paper. Take a look at those 16 KPIs. Maybe 4 of those really resonate with your institution. Maybe you can start to track 4 of those today. What we need to get at holistically is we now have these KPIs. How do we operationalize the measurement of them? Do we need tools with regards to data analytics to increase the efficiency of measuring these KPIs? And then once we have our data, share our KPI results nationally. We've been working on shortages. The hospitals and health systems have been managing these for 20 years within their individual hospital or their health system. But what we wanted to do with this KPI project was let's take all of the resources, all of the expertise that we have, bring those players to the forefront and have discussions about what is needed at a national level. Those are the KPIs that we've released, and share that information to identify gaps and opportunities that you may be missing at your hospital or your health system. The goal with drug shortages is making order out of chaos. And it's really difficult to make order out of chaos when you don't have objective data. You may have your own individual institution's data, but seeing at a national level things you may not have even been thinking about can push us forward into the evolution of our drug shortage management.
All right. That's a great way to wrap up the podcast with a call to action. A huge thanks to Heather, Chris, and Kyle for joining us today on the podcast. I look forward to future work in this space. Thanks, everybody.
Thank you very much.
Thanks.
Please join us for more Verified RX podcasts. Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified RX is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.